pregnancy. Nutrient and the course and the outcome of pregnancy. Energy requirements increase during pregnancy. Increased calorie needs during pregnancy is because of increased work of heart, increased rate of respiration and accretion of breast tissue, uterine muscles, and the placenta, as well as for fetal growth. The RNIs for energy intake for pregnancy are plus 360 kilocalories per day for the second trimester, and plus 470 kilocalories per day for the third trimester of pregnancy. A study has shown the extra energy cost of pregnancy is 77,000 kilocalories, divided into approximately 85 kilocalories per day, 285 kilocalories per day and 475 kilocalories per day during the first, second and third trimesters. However, low level of physical activity is common in the first trimester of pregnancy, and it may result in positive caloric balance. Even the pregnant woman didn't increase her caloric intake. Approximately 50 to 60% of total caloric intake during pregnancy should come from carbohydrates. The Institute of Medicine established DRIs for carbohydrates intake during pregnancy at a recommended level of about 175 grams daily. So, what is gestational diabetes? Gestational diabetes is high blood sugar level that develops during pregnancy and usually disappear after giving birth. It is usually caused by increased consumption of sugar-dense food or genetic predisposition. High blood glucose levels in mother may bring extra glucose to fetus, causing fetus to make more insulin to handle the extra glucose. Extra glucose will get stored as fat and fetus may become larger than normal.
The recommended intake of protein during pregnancy is 71 grams daily. Protein metabolism during pregnancy shift in the direction of meeting maternal and fetal needs for protein. Less protein is used for energy and more is used for protein synthesis. Proteins are used in increased in maternal blood and extracellular fluid volume, consumed by uterus and accumulated by placenta and maintain protein tissue development.
Do I need protein supplement?
It is not necessary as a balanced diet will supply adequate protein.
Essential fats are significant for fetal neurodevelopment and may be important for the timing of gestation and birth weight as well. Adequate amount of omega-3 are obtained from food sources of DHA and EPA such as fish, fish oils and seafood. EPA reduces inflammation, dilate blood vessels and reduce blood clotting while DHA is major structural component of phospholipids in cell membrane. Infants born will have higher IQ, better vision and mature central nervous system. For pregnant women, the daily recommended intake for DHA and EPA are 300 mg and 220 mg respectively. Folate includes monoglutamate and polyglutamate forms. Polyglutamates often refer as dietary folate while monoglutamates as folic acid. Polyglutamate form is naturally found in food sources. Its bioavailability is 50% on average. Monoglutamate is a synthetic form used in fortified foods and supplements. It is nearly 100% bioavailable if taken in a supplement on an empty stomach, and 85% bioavailable if consumed with food or in fortified foods. Folate involved in synthesis of DNA, gene expression and gene regulation. Deficiency of folate leads to abnormal cell division and tissue formation. Folate used in the conversion of homocysteine to the amino acid methionine. Lack of folate lead to accumulation of homocysteine. High-level homocysteine increase the risk of rupture of placenta, stillbirth, preterm delivery, preeclampsia, newborn's congenital defects, reduced birth weight. It is prevented by intake of 500 to 600 mcg per day folic acid supplements within second and third trimesters pregnancy. Deficiency of folate lead to neural tube defects, NTDs, which define as malformations of the spinal cord and brain. There are three major types of NTDs. Spina bifida is marked by the spinal cord failing to close, leaving a gap where spinal fluid collects during pregnancy. Anencephaly is the absence of the brain or spinal cord. Encephalocele is characterized by the protrusion of the brain through the skull. Inadequate availability of folate between 21 and 27 days after conception can interrupt normal cell differentiation and cause NTDs. Women should consume 600 mcg of folate per day during pregnancy, 400 from fortified foods, supplements and 200 from vegetables and fruits. NTDs develop before women may realize they are pregnant. Adequate folate should be consumed several months prior to and during pregnancy. Women who have previously delivered an infant with NTD should take 4,000 mcg of folic acid to reduce the risk of recurrence. The upper limit for intake of folic acid is 1,000 mcg per day. There is no upper limit for folate consumed in its naturally occurring form in foods. These are the examples of foods that contain naturally occurring folate. Examples of the foods are orange juice, pineapple juice, papaya juice and dried beans. Amounts of foods that contain specific amount of folic acid of each foods are listed. These are the examples of fortified foods that contain high amount of folate. Examples of fortified foods are highly fortified breakfast cereal, roll breads, pasta and rice. Amount of foods that contain specific amount of folic acid of each foods are listed. Choline contribute to structural integrity and signaling functions of cell membranes, for normal cholinergic neurotransmission, source of methyl group. Choline consumption is critical during fetal development, for stem cell proliferation and apoptosis, reducing a risk for neural tube defect. Choline can be produced by human but limited to meet the needs. It should be obtained from food like eggs, lean meats, fish and poultry, cauliflower, tofu, nuts and legumes. RDA of choline in pregnancy is 450 mg/day. I need sodium to maintain my body's water balance due to plasma volume expansion. I may exhaust sodium conservation mechanisms and lead to excessive sodium loss if restrict sodium intake. If I want to control edema or high blood pressure, I should not restrict sodium intake. I should be advised to consume salt to taste unless contradicted by a medical condition related to salt intake. Why calcium is needed during pregnancy? Fetus needs calcium to build strong bones and teeth. It helps fetus to grow a healthy heart, nerves, and muscles. Besides, calcium develops a normal heart rhythm and blood clotting abilities. Calcium is needed for pregnant mother to reduce the risk of hypertension and preeclampsia. It strengthens bones and prevent bone loss later in life and reduced overall PMS symptoms by 50%. As baby will draw it from maternal bones, impair own health later on. Preeclampsia is characterized by high blood pressure. If it is developed during pregnancy, it can cause preterm birth. It can result in eclampsia if left untreated. Eclampsia is a condition that causes convulsions and seizures, dangerous to mother and baby. How much calcium is needed before, during and after pregnancy? Women age 18 and younger need 1,300 mg per day. Those age above 19 need 1,000 mg per day. Milk, vegetables, tofu and fortified food are rich in calcium. Most people with lactose intolerance could tolerate at least 1 cup of milk. Drink lactose-reduced milk or take enzyme supplement. Divide it up for having half cup of milk 4 times per day. Drink milk with food. It's easier to digest when mixed with high-fiber foods. Why vitamin D is needed during pregnancy? Fetus needs for vitamin D increase during the latter half of pregnancy, when bone growth and ossification are most prominent. Fetus is entirely dependent on maternal stores. Vitamin D improves immune function, healthy cell division and bone health. It enhances the absorption and metabolism of calcium and phosphorus. Vitamin D deficiency will cause pregnancy complications such as gestational diabetes, preeclampsia, preterm birth. Why can't people get enough vitamin D through their diet? This is because very few foods contain a large amount of vitamin D. Egg yolk, salmon and cod liver oil, fortified foods like milk are vitamin D rich foods. Pregnant mothers should take a vitamin D supplement because most prenatal vitamins only contain 10 microgram of vitamin D. It's difficult to get sufficient vitamin D from foods alone. Multivitamins and mineral prenatal supplements may benefit women who are vegans, have iron deficiency anemia, have a diagnosed nutrient deficiency or therapeutic need for a special nutrient, have a multifetal pregnancy, do not ordinarily consume an adequate diet, and are smoking, drinking, or use drugs. Don't worry. Protein intake is generally adequate by consuming a variety of plant sources of protein, including complementary sources of protein which include legumes and grain. Protein requirements for vegan may be 30% higher than non-vegetarian. Vegan needs vitamin B12, calcium and vitamin D supplement. Iron intake increases substantially during pregnancy. DRIs established shown a recommended intake level of iron should be 23 mg per day. However, inadequate iron intakes may cause iron deficiency anemia. What is iron deficiency? Iron deficiency is ascertained by the presence of a low serum ferritin less than 15 to 30 micrograms per liter, and often a low serum transferrin saturation less than 20%. It is usually characterized by weakness, fatigue, short attention span, poor appetite, susceptible to infection, and irritability. What is iron deficiency anemia? It is a condition marked by low hemoglobin level, which is characterized by the signs of iron deficiency, plus paleness, exhaustion, and a rapid heart rate. The demands for absorbed iron increase gradually from 0.8 to 1.0 milligrams per day in the first trimester, to 7.5 milligrams per day in the last trimester. The gross total demands for absorbed iron is approximately 1,200 milligrams. Iron is utilized to increase maternal red cell mass, for the formation of placenta, and for fetal growth. Net total demands for iron is approximately 600 milligrams during a normal pregnancy, due to iron losses after delivery caused by blood losses, varying from 144 milligrams to 240 milligrams. Iron supplements are required when dietary iron intake is insufficient to meet the DRIs. Increased iron absorption from food and supplements is associated to low iron stores during pregnancy. A 30 mg iron supplement is recommended when hemoglobin levels are less than 11 nanograms per deciliter, or serum ferritin levels are less than 30 nanograms per